Okay, so why don't we continue moving distally? Here's the proximal interphalangeal joint. And again, we can see the collateral ligaments here. And then there's a volar plate that we talked about before. And then there are the flexor tendons. So the superficialis, as we talked about before, is superficial proximally here, but then the profunda goes through it, and the superficialis goes on either side, and then the superficialis attached to the proximal part of the middle phalanx. Thank you, middle phalanx, proximally here, which we're seeing in this location here on either side. The profunda goes through the center and then goes distally and attaches to the base of the distal phalanx, as we talked about before. So here's the gross specimen, a line drawing, gross specimen, and here's the MR examination showing those findings. The actual insertion of the superficialis would be to either side. This is more of a midline cut, which is thinner than the gross specimen, and so we're not seeing the superficialis insertions here. If we go to the coronal plane, we can see the collateral ligaments also of the proximal interphalangeal joint. Okay, and this just shows an injury to the collateral ligament here, which is thickening, edema, a little bit of effusion within the joint space. And here we can see the normal side on the ulnar side, and then the abnormal side here on the radial side, showing the tear of the collateral ligament. Okay, let's see.
All right. Are we looking at the collateral ligaments here? And I think there's a tear on is that the radial aspect, the radial collateral ligament distally? Oh, it's on the other side. Okay. Yeah. So you can see here that there's amorphous signal, an increased signal on the ulnar aspect of the collateral ligament, and it looks like it's at least partially torn.
Okay, so we have some oblique and sagittal views of the phalanx. There is some slight cortical irregularity along the distal aspect of that proximal phalanx, but I don't see a displaced ossific fragment. There is some soft tissue swelling. And then here on the MRI coronal images, we can see diffuse increased signal throughout the radial collateral ligament, probably a sprain injury. And again, we can see diffuse increased signal intensity tear.
Michael, are you with us?
Yeah, sorry. So we're looking at the looks like the fourth digit along the radial aspect of the shaft. There's all this edema, and it looks like there's probably separation of that collateral ligament pulled off with fluid tracking proximally, so probably a complete proximal tear.
Yep.
Okay, we're looking at the fifth digit proximal phalanx, the diaphysis there, some irregular. Yeah, that fifth MCP joint, that collateral ligament, that's some discontinuity there concerning for a tear. Not really seeing it on the axial view. Yeah, another tear.
So this is now 10:29:04. This is the original study. This is the new study. So we see the difference there.
On the second picture, I can see the ligament. It looks like it's healed.
So this just shows minimally displaced. Okay. So we've already seen some hyperextension injuries. Typically with hyperextension injuries, you get disruption of the volar plate. You can end up with a swan neck deformity or a pseudoboutonniere deformity, depending upon whether it's the distal or the proximal interphalangeal joint. That would be a type 1. A type 2 would include the collateral ligaments, because with the type 2, you've got more displacement, so you also tear the collateral ligaments. And then a type 3, you have a fracture. And then you look at the surface area, which is involved. And at least in 2002, it really required greater than a 40% involvement of the articular of the surface before, at least in this article, is considered surgical. In my experience right now is that many of our hinge surgeons will operate with much less than a 40% fracture of the articular cartilage. So you just need to describe that in the acute setting. Okay.
All right, so I think this is just describing different types. You can see in the first sagittal image, type 1, which just looks like a proximal retraction of the volar plate. And the type 3, you can see that there's been fracture and also dorsal subluxation of the middle phalanx there. And in the dislocation here, you can see a discontinuity of the extensor tendon, and the volar plate is also torn.
Now looking further at the flexor tendons, we can see that, as we've already discussed, the flexor digitorum profunda goes through the bisection of the superficialis. The superficialis attaches to the middle phalanx, and then the distal profunda attaches here to the distal phalanx. This is just what if you tease out the tendons, kind of what they look like. And here we can see the superficialis attachments and the profunda attachment there on MR examinations. Okay.
So here we have an overlying soft tissue marker, and we can see absence of one of the flexor digitorum superficialis tendons, concerning for a tear. We'd want to evaluate and see how large the defect is. Okay. So here it looks like there's complete absence of that medial aspect of the superficialis, and the lateral one also appears attenuated. And then here we can see some retracted fibers. They're irregular, and complete absence again of the medial aspect. So it looks like some of the distal insertions remain intact.
This was a complete tear, medial flexor digitorum superficialis before the attachment to the middle phalanx. Okay, Michael.
Okay, so history, trigger finger release, now with palpable mass, A1 pulley release. So along that third digit, we see a lot of fluid within the tendon sheath. We also see this kind of irregular hypointense structure. How long ago is this? I don't know. This is like some post-surgical scarring. It looks like it may be one of the flexor tendons, actually. The superficialis may be torn and retracted. Is that like the tendon retracted and scarred?
Yeah. Here are the axial images. What do you see on the axial images?
So the first axial image, I think, is through the area where we're seeing that bundle. And on the second one, yeah, we see irregularity, a lot of fluid. So I'm concerning for one of the flexor tendons is torn.
So
or is partial tear.
This was a post-operative tear. They meant to just get the pulley,
But they got the tendon.
tearing the flexor digitorum superficialis. Okay.
Let's see, on these sagittal views of the digit here, I'm seeing a lot of signal around the tendon, proximally there. Yeah, lots of fluid there as well. I'm not. Yeah, there's lots of edema in different areas along the tendons. there's a lot of fluid in that tendon sheath. Looks lots of fluid in different tendon sheaths. That's kind of complex looking, not simple looking. Could it be like rheumatoid arthritis or maybe an infection or?
So this is flexor tenosynovial, and clinically, it certainly could be rheumatoid arthritis, psoriatic arthritis, but the first thing you have to think about whether it's some sort of atypical infection. That's what you want to make sure you don't miss. Somebody's John, are you trying to talk? So, but with this kind of symptoms, the other thing would be the chronic type indolent infections, such as TB, mycobacterial disease, or I've seen it here with coccidioidomycosis. John, are you trying to do something? Because you're getting noise. John, John Yorgutis, are you with us? John? I guess John's not. Okay. Hello, John? John, I think your computer is making noise.
Okay, so here there's disruption of that flexor digitorum superficialis of the fourth digit, and you can see proximally there's absence along the lateral aspect of it, and distally it looks like it's intact maybe, but it looks torn there at the middle phalanx. So,
John, could you silence your computer? John, I think there's a problem. Would you mind disconnecting and reconnecting? Oh, I think it just solved it. Good. Thanks. John, are you still with us?
Okay, so here again we have some sagittal images of the digit. There's an overlying soft tissue marker near the PIP joint. And again, I don't see very well that flexor digitorum profundus. It seems like there's a large defect along that proximal phalanx. Here we can see some of the superficialis, but then absence again of the profundus, compatible with a tear.
Injury that tore the profunda. Good. So we talked earlier about the different pulley systems that involved in keeping the flexor tendon from abnormally displacing from the bones. And here we can see the kind of the complete system. So there are 5 A pulleys and 2 cruciate pulleys, which we see here. The most common one that we've seen, the most common one is an A2 pulley injury. We've also seen some A4s out through here as well. But they're crossings of fibrous tissues from the bone overlying the flexor tendons that keep them from abnormally displacing. And on the axial images, you can see them as these little black structures on the flexor side where the pulleys are going over the flexor tendons to hold them next to the bone. So, Michael, what do you think of this case?
Okay, so I guess the one on the the right, we see a little bit of increased distance between the flexor digitorum profundus and the proximal phalanx, and that's suggestive of a pulley injury. And I guess this one's saying it's partial. On the other side, we see kind of pretty significant increased distance. So we're calling that one, I guess, a complete A2 pulley injury.
Yeah,
And that one, I'm also wondering if maybe there could be partially a A3 as well on that second one.
yeah, certainly possibly here. Or the cruciates, which are on either side here, might be involved in this one as well. But typically, when we see this, we just call it an A2 pulley injury. And as soon as you get separation here, I typically don't use the term partial. I'll just usually say tear or not torn.
Okay. Yeah, and that second one looks pretty significant, like a bowstring. Doesn't follow the contour anymore at all.
And the typical A2 pulley tear is caused, typically seen in when you have flexion of the fingers against resistance, as you can have in rock climbers, you'll tend to pull the flexor tendon off the bone. And this would be a very unwelcome event to occur in this situation. And this just shows kind of the location of the tear of the A2 pulley. And you can see these also with ultrasound very nicely. But again, normal, abnormal, normal. So here's the tear. And this is just, they go in surgically and repair this. Okay. Let's see.
32-year-old male. Oh, sorry.
32-year-old male with pain after injury. We're seeing edema around the PIP joint there. There's some distance between the flexor tendon. There's some bone marrow edema there at the head of the proximal phalanx. Some distance between the flexor tendon and the phalanx there. Yeah, some swelling between the tendon and the phalanx there, concerning for, yeah, pulley injury. The tendons look intact.
So this is a
So 12-year-old tennis player with acute pain on flexion. We're looking at two axial images of the third digit. I don't really see much here. I don't know if I'm looking a little bit of irregularity along the margin of the flexor tendon there. Looks like there might be some irregularity there. It might be a collateral ligamentous or a pulley injury. Sorry, a partial pulley injury. And you can see that here. You can see a little bit more soft tissue edema. I honestly don't think there's a complete tear here. I think the pulley is intact.
So here we actually don't see displacement of the flexor tendons. There's always sees the thickening of the pulley, so that this was a partial tear. It was treated conservatively, but once you get displacement, I don't call them partial anymore.
Okay, so here again we can see disruption and soft tissue edema in the region of the, I'm assuming this is at the level of the A2 pulley, I can't tell here, but there is some displacement of the tendon or bowing compatible with a tear. And here again we can see the bowing of the tendon and tear of the A2 pulley.
See, so the pulley tissue has flipped deep to the flexor tendon from over here. John, are you still with us?
I'm still here.
Good. Okay.
I have some trouble with the sound.
Yeah, right. You're uncharacteristically quiet.
That's true. I'm a big mouth.
Oh, Mike, what do you think of this one?
Okay, so we see, kind of bowstring of the flexor tendon or separation from the distal aspect of the proximal phalanx, suggestive of a pulley tear.
So sagittal views of the digit here. We're seeing some separation of the flexor tendon from the proximal phalanx. Yeah, there's some bone marrow edema there at the head of the phalanx. Yeah, with some subluxation of the middle phalanx from, going forward.
So see how you get flexion. Notice you get flexion at the proximal interphalangeal joint. You get a little bit of extension at the distal interphalangeal joint with this, and this is kind of a classic boutonniere type deformity.
All right, so rock climber, so this is the MR 1 week after injury during crimp hold, and then also did an ultrasound 4 weeks after injury. And so we're looking at the pulley system here. Honestly, the A2 pulley looks intact on the sagittal view, on maybe just a little bit of increased signal along both sides, and there's a little bit of displacement, I think, there at the A4 pulley. Yeah. And so you can see the separation at the A4 pulley, and that's concerning for an A4 pulley tear.
So we have another rock climbing injury 3 weeks ago. Again, we can see a lot of edema and irregularity in the region of the A4 pulley, compatible with a tear.
Okay, Michael, what do you think of this one?
Okay. So at the distal aspect of the middle phalanx, there's increased distance between the flexor tendon and the phalanx, concerning for a pulley tear. However, there's also this kind of a hypointense structure right there. Like kind of, I don't know if that's some like scarring, like if this is and I guess circling, maybe there's degenerative change. Like I don't know, there's just and there's a little bit of like chronicity to this. Yeah, chronic pulley injury.
There's actually remodeling of this distal joint. I did look at that because it's been chronically subluxed due to the pulling of the flexor tendons from the wrong direction because of the chronic A4 pulley tear. Not quite really. This is, I don't think this is really a named deformity.
Middle-aged female with triggered thumb for several years. I think we're looking at the thumb here. I think we're at the MCP joint, where the soft tissue marker is.
So this is where the patient has the symptoms. Yeah. Are you familiar with what a trigger finger symptoms are? So what happens when you get to is that when you try to flex the finger, it'll stop. And then if you force it, you'll feel a pop, and then you can fully flex it all the way. And so, and it's really quite common. I've got in both of my thumbs much of the time, but right now I can't make it happen. But you can feel it just stop at that location until you force it. And it's typically due to a little bit of widening of the flexor tendon, and that widening gets caught in one of the pulleys and can't get through very readily. And sometimes if you get irritation there, you can get edema around that spot. My experience is the vast majority of these we can't see on an MR examination. So I don't think MR is really a good technique, but you look for signal abnormality, thickening, and something that looks like tendinosis or focal widening of the flexor tendon in that location.
It's very easy to diagnose clinically. So I see no reason for MRIs.
Right. Yeah, exactly. We don't. Right. I've seen a couple of cases where the people have been sent in to have MRs for trigger finger, but that's really uncommon, and it's usually from someone who's not very familiar with disease.
Well, ganglion cysts can be a problem in some cases. It's hard to tell sometimes. You get hourglass appearance of the flexor tendons, and then it's hard to tell sometimes whether it's a ganglion cyst or not, especially if it doesn't move.
Here you can see some separation at the A2 and A4 pulleys. I don't know if they're tears of both. Yeah, all the way along. Yeah, maybe. Oh, okay. So is that just fluid through the flexor tendon sheath, and this is the tenosynovitis of the flexor tendon? Yeah. Okay.
Here you can see a little separation right down the middle.
Oh, it looks like a longitudinal tear almost.
Here.
Yep.
This is the profunda superficialis.
A lot of. Okay.
This was a
Longitudinal split tear of the profundus.
Profunda with secondary tenosynovitis from it.
Okay, so here we have an overlying soft tissue marker along the proximal phalanx, and there's absence of that flexor digitorum profunda tendon with soft tissue edema concerning for tear. And here we can see it's retracted there along the proximal phalanx. And here again on the axial images, we can see complete absence of that tendon compatible with a complete tear. And then we have reconstitution.
Would you have difficulty fixing this one?
Oh.
This is not a no man's land. This is in man's land. So this is fixable. No man's land is where the sublimus or superficialis attaches to the middle phalanx on either side. That's the distal portion of the no man's land. It starts at a distal palmar crease and then goes to the middle of the middle phalanx of the finger. And that's in all the fingers.
Thanks, John.
And when you're dealing in that area, that's a place where the hand surgeon sweats, not only just a ordinary everyday surgeon, but the hand surgeons sweat that area also. These are very difficult to deal with.
Is that because that's where those two tendons are crossing over, or why is that area difficult?
No, it's the pulleys. The pulleys scar in with a repair, and no matter what you do, that you keep for.
Thanks, John.
Damn it. Sorry about that phone call. There's just nothing I can do about it.
That's okay. Michael.
Okay, so 53-year-old male injured in a fall, cannot bend fourth digit. So I see a lot of edema and swelling and soft tissue swelling involving that fourth digit. Okay, so I see the slips of the like superficial flexor going around, but I don't see the profunda right there. Like it's absent, it's missing compared to the other one. So I'm guessing there's a full thickness tear, and now we're seeing it reconstitute. So yeah, so on sagittals we can see that more clearly. The deeper one just completely torn or retracted.
"42-year-old male with post-op pain." Okay, so we're seeing one of the second flexor tendon there. There's the third. It's got some signal within it, longitudinal signal concerning for maybe a split tear on the axial views there. Yeah, the superficialis tendon, yeah, split tear. Yeah.
So a 53-year-old physician with rheumatoid arthritis unable to flex the thumb. Here here. Looks like there's complete tear of the, I think both tendons, but definitely the deep tendon, deep flexor tendon is torn.
Yeah, in the thumb there's only
one. Right, yeah, sorry. And it's, right, the flexor pollicis longus is torn, and you can't see it there. And there's some edema of the abductor muscle there as well previously, but you can see it reconstitute distally. And then there's also tenosynovitis of the fourth digit tendons, flexor tendons.
Okay, we have an inability to flex the distal phalanx after a laceration from a broken bottle. And we can see a complete tear of the flexor pollicis longus there at the level of the IP joint. Oh, fourth digit. I thought we were still on the thumb. Okay, so then we have a complete tear of the superficialis there at the level of the profunda tendon at the level of the DIP joint.
Michael.
Flexion difficulties after knife fight. So this one's not so subtle. It just looks like there's a laceration and a complete tear of both flexor tendons with proximal retraction, lots of edema.
Yeah, I think you're probably right there. I need to see other images to see whether the superficialis was involved as well.
Because it might have already plugged in, but it's hard to tell.
Yeah, we may be on either side, but I think you're probably right. This probably is a tear of both, but I don't. Okay.
17-year-old female cut on hand 1 month ago, evaluated for injuries in the second and third MCP joints. Looking at the second digit flexor tendons there, there could be a split tear there. Yeah, so they're absent, concerning for a tear and some retraction, still absent. More proximally, yeah, and there they are. Yeah, we can see discontinuity there. It's a full thickness tear.
How are these to fix, John? John?
Yes.
How are these to fix in this location?
Usual suture.
It's really right at the metacarpophalangeal joint, where the laceration was.
I don't think it makes any difference at this joint as to how you fix it.
Okay.
The main thing is as long as it's not in the pulley area. But this is still a no man's land company, so you have to be careful with the sheath of the tendon, whether you repair that or you leave it alone. It's kind of a tricky, and there are a lot of different opinions, and you can go nutty reading the literature. And there's so many different suture ways and material to use, and frankly I can't decide what I would use today.
Okay, thank you.
There's also nerves to be considered. I don't know whether you're going to get into that or not, but suturing nerves and tendons. Bunnell used to use a suture that he's very well known for. They don't use it as much as they used to. They get more close to the end of the tendons, and they try to go through the center of the tendon and put sutures in the body of the tendon rather than just in one layer. They go to like 4 layers or 6 layers. So they get a good connection in the entire circumference.
Good.
And the tendons the sutures are interesting. They use some braided steel sutures like 6-0 in size, which is like a hair, but they got the sutures for nerves that are 10-0, and you need a microscope to see that just about.
Great. Thank you.
On this sagittal image, is the irregularity of the osseous structures of the phalanx, is that just because we're kind of out of field of view?
And the fact that you got a chronic lesion here, there's remodeling of the bone.
Okay.
There's something going on
Yeah,
all the way to the skin there, isn't there?
yeah, there's definitely a lot of irregularity of that proximal phalanx, and there's also a lot of soft tissue thickening there, and I think there's a tear of the deep flexor tendon and separation there. So
Yeah. So this was a chronic
A
tear.
lot
It was not
of scar tissue. When you get into this situation, like I said the other day, 10 hours is your magic number. After that, things get harder for 10 days. And after that, then it's really hard to take care of these. You get the secondary repairs, which are never that good.
So this is a chronic tear that's scarred in, and it's been there long enough to get remodeling of the bone.
To fix this, you really need some well, I'm not sure. I wouldn't try it to fix it. I definitely would get a hand guy to do it. And he'd probably send it to his best friend.
Or worst
And that's a joke.
So here on the coronal and sagittal images, I don't see either of the flexor digitorum tendons very well concerning for chronic tearing. I'm not sure how recent the injury was.
This is Flexion tenosynovitis, and a lot of
When you have tenosynovitis, you can remove the tenosynovitis and early motion and get pretty good result. So it's not a disaster to have tenosynovitis.
okay, good. So this was very chronic, and in this situation, so first you have to be concerned about infection, make sure that you don't have that. Then you have to think about trauma, and then this is a single digit. The digit is enlarged. Then you have to think about dactylitis, which typically means that you're dealing with psoriatic arthritis. So, and I don't remember. I think this was post-infectious in this particular patient.
If it's an active infection, it's extremely painful, and the finger is very, very swollen. So this doesn't look like anything like that.
Yeah, this is.
It may be something chronic.
Yep. Okay. Michael, what do you think of this case?
So it just looks like there's a lot of fluid within that third digit flexor tendon sheath. From what I can see on this cut, the flexor tendons are intact, although they're kind of displaced. More distally, they look fairly irregular, so it's either tendinosis or partial tear. And I think there's tenosynovitis, but I'm wondering if they're on sagittal, they look like they're intact. So I think there's a component of tendinosis and tenosynovitis. I don't think there's a tear, right?
Yeah. So this was another tenosynovitis, and I don't remember the underlying etiology of the tenosynovitis at this patient.
65-year-old female with a volar mass. I'm seeing osseous irregularity there at the base of the third digit. It doesn't look like it's part of the joint. Yeah, still, I mean, there's some osseous irregularity there. It could be part of the tendon. Looks like it's going around the tendon, probably maybe some calcifications in the tendon sheath. Calcific tendonitis.
This will be superficial to the tendon. The tendon will be closer to the joint. So this is some kind of a mass.
It was chronic calcific tenosynovitis, really. Yeah. I don't remember the etiology.
Looks like in the tendon distally, John, but proximally at the joint level, MP joint, that looks outside the tendon.
Yeah, I think
Doesn't
this is probably primarily due to a lot of synovial thickening and chronic synovitis and calcification within the chronic synovium. Is what
Gotcha.
I guess would be.
I've never seen a case like that.
All right, are we looking at the third digit here? Skin marker, there's a little bit of fluid within the tendon sheath, and looks like, are we looking distally? Are we looking, there's a little bit of fluid throughout the tendon sheath. I think this is just a mild case of tenosynovitis throughout.
So this patient couldn't flex and also had limitation of extension.
Oh, okay.
Of this finger as well. And notice that you have just a lot of, you don't,
A lot of
fat that you have.
Right, it's all soft tissue.
Just a lot of fibrous thickening right through here. And it's very nodular.
Is that a skin lesion, John?
Well, this is subcutaneous lesion here, and these are hard nodules that you can palpate. And this was definitely
on a sagittal view. That's not where the crease is. That's right in the middle of the
tendon
phalanx. So
yeah, so
that's a skin condition of some kind. Yeah. Maybe old laceration.
No, this is Dupuytren's contractures, John.
Oh, Dupuytren's, my goodness. That's not a common area.
Yeah, that's usually more proximal than this. The patient had it in the palm.
Usually it's in the hand.
Yeah.
Signal fibrous bands with Dupuytren's?
Typically, it looks just similar to that.
Okay.
Yeah. You just get those little fibers, and they usually, if they put markers on it, they'll put markers on it, and you can see the fibers thickening right where you can feel the nodules. And it will often adheres to the tendons, reducing motion.
So here it looks like there is some subluxation of the distal phalanx with respect to the proximal phalanx, and there is some cortical irregularity of the phalanx. So here we have the MRI, and it shows surrounding marrow edema compatible with an acute fracture. Yeah.
Okay, well, why don't we end here? And we'll talk about inflammatory disease of the wrist and hand starting next week.
Great.
Okay.
Thank you.
Thanks. Any questions? No.
Well, have a great weekend, everybody.
Thanks, John. Same with you.